Hello, I'm Dr. Leslie Citrome, Clinical Professor of Psychiatry and Behavioral Sciences at New York Medical College in Valhalla, New York. How many times have you been shown a graph and it says, oh, p-value is less than 0.05, it's statistically significant? And how often have you been told that, oh, the p-value is less than 0.001, so it's a very important outcome? Actually, that's problematic. P-values don't tell us everything we need to know. And we suffer the tyranny of the p-value, as I call it. We focus exclusively on the p-value and forget what it actually means. The p-value is not an indication of how strong that comparison is in terms of an effect size. It just tells us how strong the likelihood that any difference is not due to chance. It tells us whether we're dealing with the truth or not. The smaller the p-value threshold, the more convinced we are that we're dealing with a true effect and not something that is a fluke. The p-value is not the same as an effect size. Effect size tells us how big the treatment effect is in terms of reduction of symptoms or any other outcome that we're interested in. The greater the effect size, the more convinced we are that we're dealing with something that's important and that may be clinically relevant to our day-to-day practice. It doesn't say anything about the statistical significance, mind you, and the effect size is not the same as a p-value. In fact, you need both. You want to assess the effect size of something that's statistically significant. There are many kinds of effect sizes, and you probably have heard of relative risk and odds ratio and hazard ratio. Those are all relative effect sizes, and they can be confusing to interpret. I prefer absolute effect sizes, and you may have heard about attributable risk or Cohen's d or number needed to treat and so on. P-values and effect sizes are quite different. I'm going to give you an example that contrasts absolute and relative risk from something that was in the news not that long ago. A headline was, "Aspirin Cuts Breast Cancer Risk." And it talked about this new piece of research that backs the idea that aspirin actually protects against certain kinds of breast cancer. And the press reported that women who used aspirin or similar painkillers at least once a week for 6 months reduced their risk of breast cancer by 20%. That's astounding, right? In each story, the media highlighted the change in risk associated with aspirin that is 20% lower risk. And the implied message here is that women should take aspirin routinely to avoid breast cancer. But let's take a look at the absolute risk. The risk of developing breast cancer for postmenopausal women who do not take aspirin on a regular basis is 955 over 194,884. So I'll say that again. 955 divided by 194,884 in person years. So what does that come out to in percentages? 0.49%. So that's the baseline rate, we think, of breast cancer in postmenopausal women. If we look at taking an aspirin a day for at least 5 years and reducing the risk by 20% in relative terms, that comes out to, I won't do the math with you, 0.41%. So we're going from 0.49% to 0.41%, and the absolute risk reduction is only 0.08% versus a relative risk reduction of 20%. So another way to say this is that a woman's chance of being free from breast cancer over the next 5 years was 98.4% if she used aspirin and 98% if she did not. That's a lot different than saying you're reducing breast cancer risk by 20%. This is one way that relative measures will be deceiving. I like absolute differences, like number needed to treat. How many patients needed to be randomized, let's say, to an experimental treatment versus placebo before expecting one additional outcome of interest? Small number needed to treat values means a bigger difference between what we're comparing. Let's say, for example, drug A results in remission 50% of the time, and drug B results in remission 20% of the time. Relatively speaking, we would say drug A is 2.5 times better than drug B. But what does that actually mean in day-to-day practice? We can calculate the number needed to treat. It's easy to do. What's 50% minus 20%? That's 30%. 30 goes into the number 100 3.3 times. We'll round it up to 4, and the number needed to treat is 4. In day-to-day practice, choosing A versus B will encounter one additional remitted patient every 4 patients when we choose A. That's actually pretty good, and we'll probably choose A. However, maybe A didn't work in that individual person in the past, so I won't choose A for that one. And maybe A is not available on the formulary, then I can't choose it. Maybe A is associated with a side effect that the patient absolutely wants to avoid, then I can't use A. So we have to use our brains when looking at effect sizes and personalize the treatment decision. But the first step is interpreting that clinical trial data and looking to see how relevant it could be in your day-to-day practice. I hope this has been useful. There's lots of materials on the web regarding effect sizes, and it's something that we should all learn about. Thank you for your attention.